Good afternoon, everyone. I guess it's noon on Pacific Coast now. Some of us East Coasters, it's later in the day. So welcome to everybody today for our Lunch with Docs. We have a really interesting discussion today with Dr. Christina Vaughan and Dr. Drew Kern on advanced therapies and palliative care. Dr. Vaughan and Dr. Kern, thank you for joining us today. Real quick, everyone, just a little bit of housekeeping before we get started. If you guys would like to ask questions throughout, we will probably hold the majority of them until the end, but feel free to chat them to us and I will keep track of those, and then maybe at the end we can also unmute and allow those who want to ask their question. It might be easier for you to ask your question in person. We'll do that. So I want to welcome you too, and I'm going to hand it off to you guys. If you could just give us a little bit of background as to how you got into movement disorders to begin with, and then the whole palliative model and the areas of expertise that you guys are serving in.
Sure. Well, thank you so much for having us. We're coming to you from the University of Colorado in Aurora, just outside of Denver. And we both work in the space of neurology movement disorders, but I have sort of pivoted towards palliative medicine. So just briefly to answer your question, I went to medical school so that I could focus on movement disorders, neurology. From a young age, I was exposed to Parkinson's, and so it was really close to my heart and a real inspiration to go in that direction. And so once I finished all my training in neurology and movement disorders, I practiced in that area for several years and decided I wanted to get some additional training in palliative medicine, which I'll explain a bit more about briefly in a few minutes. And so took another fellowship to focus on that, and came to the University of Colorado a little over 3 years ago, because already here at the university had been created this hybrid of neurology and palliative medicine. And so it was already created by my predecessor. So I was excited to come here and continue the work and try to grow the program. So now I see patients with all sorts of different neurologic conditions in the realm of my neuro-palliative care clinic. And thankfully, it's highly enriched with Parkinson's patients and patients with Parkinsonisms, because colleagues like Dr. Kern and others are kindly sharing patients with us in our clinic. So I'd say the majority of the patients I see fall under the category of Parkinsonism. And I'll let Dr. Kern introduce himself too.
So I obtained an undergrad and master's degree in neuroscience. I was always interested in cells and cells firing and neurology. Similar to Dr. Vaughan, very young in my career. Ultimately decided to go to medical school, and during medical school I also was interested in advanced treatment options and did a 2-year translational research fellowship on stem cells and application in Parkinson's, as well as in Alzheimer's using a Down syndrome model. From there, completed medical school then and went to residency and completed my fellowship in movement disorders and advanced treatments, specifically DBS, over in Toronto, and was fortunate to get recruited back to Colorado. I've been here now for about 5 years. I'll also add that the main campus is at Anschutz, as most of you know, which is in Aurora. But we have a number of other satellites throughout the rest of the state. Dr. Vaughan and I both see patients also in Boulder and share patients in Boulder, as an example. So that's been what I do now, is more on the realm of advanced treatment options in Parkinson's disease and seeing patients in the later stage of their disease. At least 75% of my patients fall under that type of heading or category. And we'll be going through just how we interact together in this collaboration with the neuro-palliative care, Dr. Vaughan and myself, for the betterment of the overall care in our patients.
Awesome. So I know everyone's excited to hear like how you put together palliative model and the advanced treatments together. And like you said, we have had a few previous live streams about palliative care, and I think we can't hear it enough because I still think we often equate palliative care to hospice care and more end-of-life care as opposed to quality of life care. So I'm going to pass this off, Dr. Vaughan, because I know you have a PowerPoint that you wanted to share.
Can you see that okay?
Yes.
Should I make it bigger?
You can with the slideshow preview. There you go.
Great. All right, we don't have very many slides. We're going to try and keep this as conversational as possible, which I think is a lot more interesting and practical. So what we want to start with, the launching point really, is what we're trying to do. All of us that work in the area of Parkinson's disease care and research are really striving to help patients live as well as possible for as long as possible, and with a focus also on caregivers and family. And to do this, we focus on treatments, whatever the intervention is, and that's what Dr. Kern specializes in, among other things, the advanced treatments available to people who have Parkinson's. So we'll focus on that today. And the other piece that goes hand in hand with the treatments, the actual medical side, is the somewhat less medical side, which is the supportive side. And supportive care is another way of naming palliative care. And as Anissa said, sometimes people have heard of palliative care and associate it with the end of life. But as you see here, as I've documented, the goal is to live as well as possible, as long as possible. And that's at any stage of Parkinson's or whatever the condition is, the chronic neurologic condition is. And so just briefly, as we said, I would review palliative care or palliative medicine, just to be sure we're all on the same page. So as I said, this is my subspecialty within neurology. It's a medical specialty that involves fellowship training, and it's also an approach to care. So palliative care is also an approach to care of persons affected by any serious illness. And again, I can't stress this enough, at any stage. I would love to see patients at the time of diagnosis, when symptoms are mild or subtle, and introduce what palliative care is then, because there's a lot of things we can help with even at that stage and at different time points along the way, which I'll highlight in a slide in a moment. And so at its core, palliative care is the focus on improving quality of life and reducing suffering by addressing sort of 4 key areas: complex medical symptoms, any physical symptoms, emotional symptoms, we try to help with all of those. We also focus on psychosocial issues, the practical side of family dynamics and housing situations, transportation, all of those things. We also focus on spiritual well-being or existential questions in well-being. And we talk about planning for the future. Next steps, where are we going? If people want to talk about prognosis, we talk about that. We talk about having documents in order and having everything sort of lined up with a plan for the future, because a lot of times in the face of uncertainty, whereas, we don't know exactly what's going to happen next with most neurologic diseases, there are some things we can plan for and know with certainty. So we try to bring that element of certainty into the picture and plan for it. And so we like to say that our field is high touch, not high tech. There's nothing fancy or high tech about palliative care, but it is meant to be very holistic. And so just briefly, I want to emphasize that the word palliative is not a scary word at all, despite some beliefs. It comes from this word palliare, which means to cloak. And I love this word, and a lot of people say you should change the name and call it something else, but I want to hold true to the word palliative, because the image of cloaking in an extra layer of support, I think, is really spot on to what we're trying to do, to be another layer of support. And we do this through a team where the patient is at the center. And I would say the patient and family together are at the center, but certainly the family is part of the picture, or whoever's close to the patient. And then we have a team. Palliative care is best provided in an interdisciplinary team, which includes, in this case, a neurologist. That's the physician or a physician assistant, nurse practitioner, a social worker who focuses on the psychosocial piece, thinking about resources, programming, transportation, support groups, all those sorts of things. A nurse that can serve as a case manager, a chaplain or spiritual counselor that can talk about coping strategies, thinking about spiritual well-being. And together, That encompasses what is the palliative care team most commonly. Plenty of other people could be in on the team, psychologists, sometimes different therapists, but at its essence, at least on our side here at the University of Colorado, this is the layout of what our team looks like. And that's how we provide palliative care in conjunction with our colleagues in movement disorders. And so the last slide that I'm going to show right now is just a point, sort of a timeline to think about points along the trajectory of Parkinson's, or frankly, any other chronic disease where palliative care could be particularly helpful. So DX is diagnosis on the left, and that stands, that's the time point when someone is diagnosed with Parkinson's. Palliative care would be helpful at that time to discuss goals of care, to identify a decision maker. It's never too early for any of us, diagnosis or not, to identify who we would want to be our voice if we couldn't speak for ourselves about medical decision making. So identifying that early on is great, and we can help with that. A little further along, we can bring in the whole team and talk about spiritual wellness, deal with some complex symptoms, psychosocial needs, care coordination, and bring in the team for that. A little further down, months, years later, who knows, we can talk more about prognostication, manage some more severe symptoms. Sometimes severe constipation is something we can tackle well. Sometimes pain in Parkinson's is something we can help with. Also thinking about legacy work. Moving forward still in time, we can organize family meetings to help with communication when maybe not everyone in the family is on the same page, or if we want to bring in other providers involved in the patient's care to have a sit down all together family meeting. We can help with the MOST form, which is the medical orders for scope of treatment. In other states like California, it's called the POLST, P-O-L-S-T, the physician orders for life-sustaining therapies. And really all that is documenting your wishes about what you would or wouldn't want medically if you got really sick. So we help with conversations around that. And then further down the road, we introduce the idea of hospice, if that makes sense to talk about, and sort of demystify what that is. And then years later, perhaps we talk about severe symptoms again, maybe pain is more of an issue, anxiety, delirium, if that's a problem for people that are really frail and at the end of their life anyway, these can be really relevant. We talk about care transitions, if it makes sense to bring in more help or consider moving to a facility. And then once someone does pass away and die from whatever the condition is, in this case Parkinson's, but whatever it is they die from, hospice is hopefully already on board to help with end of life. And at the end, once someone's died, hospice stays involved, if helpful, to help the family with grieving. So it's a huge trajectory. I mean, this could last decades, but I shrunk it down to fit into a slide to show time points or opportunities where palliative care can come alongside the movement disorders neurologist to help support patients and families with Parkinson's disease. So those are my main slides for now, and I'll turn it over to Anissa to engage in some questions for Dr. Kern and for me.
And I wanted to just make a comment about that slide because it's a very good depiction of the whole timeline. But, in my experience of working with people with Parkinson's, unfortunately, not having access to this model, which I think everybody should, they missed a lot of that front end support and information and coordination of services and care, and they didn't even know what they didn't know until they entered crisis phase, much later. And how nice would it be if we could make this a standard practice for all movement disorder centers, for everyone that's diagnosed to adopt this framework of the supportive model from the very day of diagnosis to the very last. So thank you for sharing that. So could you explain what advanced PD is? I think this is the question for Dr. Kern, because that's part of the discussion today is advanced therapies for advanced Parkinson's. So could you give us an explanation of what that really means?
Right, so it's a term that we have that doesn't really have any clear definition, first off. So unlike our epilepsy, i.e. seizure neurology colleagues, who have a clear definition for medication refractory epilepsy, meaning patients on 3 drugs and still having epilepsy, those patients automatically get referred to surgery, as an example. We don't have such clear definitions in the realm of movement disorders. So you hear this term used quite a bit. And there have been a couple pieces put forward to say we actually need to come up with a firm definition of this term if we're really using it. There's been a lot of think tanks that have also been participating in about this term. Tend to think about it in the context of when the individual develops dyskinesias, is on medication 4 or 5 times per day, every 3 to 4 hours, and still having fluctuation of on-off time by a total of maybe 2.5 to 3 hours during the day. Those are very loose definitions that we tend to think about for patients with regards to the motor symptoms. There's also non-motor symptoms that are obviously associated with advanced stages. Those can include, and I know Dr. Vaughan can go into greater detail about this, anxiety, depression, hallucinations, psychosis. These are other findings that we would certainly could consider as advanced stages of a disease as well. And so the term advanced, as you're hearing, doesn't really have a clear definition, although in movement disorders, we certainly still tend to use it. And a lot of movement disorder neurologists will think about it in those type of cases that I've presented to you thus far. I think one other point is, as we'll go through, with advanced treatments, the term is actually probably not the best because a lot of these treatments probably should be introduced much sooner in the disease course rather than, quote, in an advanced stage. So maybe another term would be non-pharmacological treatment as an example that probably should be used, but at least the terminology is what we have to deal with for today.
And I would just add, if I could, the link between advanced Parkinson's and neuro-palliative care, which is to say that a lot of folks assume that palliative becomes more relevant in advanced stages of Parkinson's when someone's had Parkinson's for a number of years. And while that's true, we can be quite helpful. As I said before, our hope is to be helpful from the beginning, including advanced therapy and during times of advanced disease. And as Dr. Kern said, a lot of times it's the non-motor features of Parkinson's that really become problematic in more advanced, long-standing Parkinson's disease, as he mentioned, and we certainly do help with that.
And those are the ones that are hard to treat and really do need the extra support. So you've mentioned, of course, movement disorder neurologist, and there's a lot of people on here that understand what that means, but there may be people that are on our program today that do not understand what the difference is between a general neurologist and a movement disorder specialist. Can you talk just a second about how they differ and what they offer?
Sure, I'll take that one. So a neurologist is somebody who is trained in neurology, has completed a residency in neurology, and they can either be board certified or not board certified. Board certified means that they take the federal exams in the United States. Now, you can have an excellent neurologist, for example, trained in Canada or elsewhere, who's not board eligible because they didn't do a residency training program in the United States. Hence, they're not eligible to take those boards, but they could be excellent in themselves. So that's just what board eligible neurologist means. After neurology residency, then someone can go on to do a movement disorders fellowship training program. Most of those nowadays are at least 2 years of additional training on top of this. So in this context, the physician is only seeing and treating patients with movement disorders and is at an institution that has movement disorder neurologists, obviously, training that individual to take care of those patients. So somebody that's, quote, calls themselves a movement disorder neurologist is somebody that's completed neurology, is a neurologist, and also has completed a movement disorder fellowship training program. Now, the term movement disorder specialist doesn't have any clear definitions. It could be somebody who hasn't completed a neurology fellowship training, somebody who isn't a neurologist, that tends to try to focus on seeing patients who have movement disorders. And there can be a wide range of expertise and formalized training within that field.
All right, so if someone wanted to come in for advanced treatment and appointment to discuss options, what would that look like?
Right, so any patient that gets referred to us for, quote, advanced treatments or for, quote, DBS is another referral that we might receive from a general neurologist, primary care provider, geriatrician, family internist. They automatically come in and have a referral to advanced treatments, so they don't automatically go right to the DBS evaluation process. And the reason for that is twofold. One, a number of patients don't necessarily and are not interested in brain surgery, but there's a number of other treatment options that might be available. And hence, we're preventing patients potentially from learning about these opportunities simply because they do not want to hear about DBS, which is perfectly fine, but they probably would like to hear about other treatment options. And the third reason is, or a second reason, is because some patients are referred, quote, just for DBS. However, you know, in evaluating the patient, we find out in actuality, they're really not a good candidate for DBS to start off with. For example, the diagnosis is incorrect, which is why they might not have been responding very well to medication. And we've then allocated a lot of resources for a treatment option that the patient is automatically not qualified for. For example, obtaining a brain MRI, having on-off testing, seeing neurosurgery, other resources that we might use as far as our DBS evaluation that they don't necessarily need. So the process goes into an hour-long appointment minimum. The history is completely reviewed, medications reviewed, the diagnosis is also reviewed, confirmed or refuted or questioned. Imaging is reviewed with the patient if there is any of that are available. And then we discuss what are the goals. What does the patient really want to achieve? So an individual, for example, that says, I have a lot of imbalance, for example, and I'd like to improve my balance. Well, we're not necessarily going to go jump into DBS because that's not really a symptom that's going to be improved with DBS. So we then tailor what are the treatments that can be utilized to benefit the main symptoms that the patient has a complaint about. And if, for example, that it does appear that DBS might be a good option, or a clinical trial, or duopa or duodopa, then, or our gene clinical trial, then we'll refer the patient onward to those treatment options. They've already seen a movement disorder neurologist, so they've kind of have a little bit expedited type of referral in that process. And we'll also make appropriate referrals thereafter, such as a patient might be referred to us for Parkinson's disease, needing DBS outside provider. In actuality, we identify that the patient really does have multiple system atrophy, doesn't have Parkinson's disease. That's why they're not doing very well. They're not a candidate for a number of clinical trials, nor are they a candidate, unfortunately, for DBS. There are some clinical trials ongoing in multiple system atrophy, so we will refer the patient on to those clinical trials, but also we'll refer the patient on to palliative care, simply because, as you can imagine, that's a devastating A, diagnosis, B, they've had a reversal in what they previously had thought as their diagnosis, and now also they were hoping for a treatment that would help them, and now they're told that this is not really a treatment option. So they basically get, in one appointment, as hard as it is, they get hit 3 times. And that can be very challenging for an individual, and that's where we really rely upon our neuro-palliative colleagues, Dr. Vaughan, to help us in the overall care of these patients. And there's been times where we, fortunately, she might be in the clinic at the same time while seeing patients, and we'll just pull her in and say, can we have you in, or have the palliative care nurse come in and talk with the patient. I've had an unfortunate scenario where I had a patient come in to be referred for DBS, and in actuality, the patient had a devastating disease called CJD, which is life expectancy was less than a year. And the patient went on to hospice care when they thought they were coming in, for example, DBS. And without our palliative care colleagues being right there for us, that patient's psyche would have been really, really hard. But palliative care was able to work with the patient and the family for that very, very difficult time period.
Wow, that sounds so important and comprehensive. Like, I can't even imagine, just the opportunities there to support people when they think they're appropriate for something and it turns out they're not, and just the devastation when you kind of get in your head, hey, I want to have DBS, this is for me, and then it turns out that that's not even appropriate for you because you don't have the diagnosis that you initially thought that you had. So can talk a little bit about just that whole team approach. I know you talked about a little bit about just that whole personhood that you bring into this evaluation for DBS, the palliative model, and how that plays into it a little bit more, and then some of the other treatment options. I know you mentioned duopa, and I've had a couple people ask about talking about the gel form. Maybe they didn't appear appropriate for DBS in your evaluation, that actually they would be more appropriate for duopa.
So if we could go to maybe the last slide. I've got a couple slides real quick here. There. So one of the great advantages we have at the university is just the number of experts in their specific fields. And so the DBS team, and really the advanced treatment team that we'll talk about in a little bit maybe, as you see, includes a huge number of individuals in various specialties related to movement disorders and Parkinsonism and other movement disorders. So that's one big strength that we have, and all these individuals are involved in our DBS team. So an evaluation for DBS involves seeing the movement disorder neurologist, the neurosurgeon, neuropsychologist. They have an MRI that's read and reviewed by the neuroradiologist. If there's any other rehab needs that we can identify, we've got physical therapy, speech therapy, physical medicine, rehabilitation. They also see our DBS nurse as well, surgical scheduling, and they have an access coordinator as well. But all patients coming in for DBS evaluation, all of them get evaluated by a palliative care neurologist. And I think that is, we started doing that about a year and a half ago now, since Dr. Ojiman and I are the directors of the program, and find that this is absolutely invaluable because we can talk about what the goals of the care of the patient are, but we're really focused on the movement. So how much on time, how much off time, how much rigidity, how much tremor do you have, how is this limiting you? But as we know, that doesn't really address what might matter the most to the patient, and also what is the caregiver support like as the individual A is going through this process. What was it like before, and what might it be afterwards? And certainly after doing DBS, there can be a great change in the family and caregiver dynamic. So having palliative care evaluating the patient during the initial evaluation, getting involved early on, I think is absolutely essential. And I think Dr. Vaughan can speak more to that point.
Sure. I've been thrilled that our DBS team has included us in neuro-palliative care and had that idea, because it's an opportunity for us to meet patients who we may not have met already in the course of their Parkinson's, and an opportunity to provide more support and to try and fill in some gaps, if there are any, regarding other programs and support groups or whatever it is to help people. And I think one of the big tools that we use in palliative care when we're meeting with patients who are considering deep brain stimulation surgery, DBS, or other significant interventions is what we call the goals of care conversation. And, we throw around this term a lot, goals of care. And it sounds kind of obvious, but it is more than just thinking about goals. In other words, if I were to ask you, what are your goals of care? A lot of people would say, well, I want to have less off time, I want to have less tremor, or take less Parkinson's medications. There's just a whole host of disease-specific goals that people might say. But if we approach it in a more holistic way and step back and think about the big picture, which is something we try to do a lot in our neuro-palliative care visits, what we're really asking is, what are you hoping for the future? What do you want the future to look like? What kind of quality of life do you want to have? And what does quality of life even mean to you? If you think about it, quality of life could mean a lot of different things to a lot of different people. And on the medical side, it's easy for us to make assumptions about what patients and families want. But until we ask, we really don't know, right? So we might assume, well, this person's coming for DBS. I'm sure they want to have, less tremor. I'm sure they want to have less dyskinesia, extra movements. I'm sure that's what they want. When in fact, they want to be able to travel again, or to spend more time with family who's far away, or whatever it is. The actual goals are bigger than just talking about tremor or medications. And so the goals of care conversation, I'm going to go back to my slide here, is meant to take what's the patient and family most want and what they're hoping for, and to match that with what's possible medically, and to make sure that the goals are in alignment with what reality is. So we have a long conversation where we get to know the patient and family when we're talking in a goals of care conversation. We try to understand what life was like before the Parkinson's, and to get a sense of what somebody feels is most important. If they had a hobby that really brought them a lot of joy, but they're not able to do it, or not do it as well right now. Maybe it's possible that we can work on that and get that going better with future DBS or another advanced therapy. And so we try to elicit from people, what sorts of hopes do you have in the way of function, in the way of experiences in life? What values do you have that are most important to you? For some people, for example, staying at home is one of the most important things. And some patients say to me, I never want to go to a facility, I want to stay at home no matter what. So we think, okay, what in our treatment plan in the future will allow them, or hopefully facilitate, staying at home, and how can we best support them as our team to accomplish that? So again, we elicit values, hopes, what they're hoping for, wishing for. We try to understand how a person sees him or herself. The personhood piece is really important. We don't want to just see somebody as a diagnosis, as someone with tremor predominant Parkinson's, or with major dyskinesia. We don't want to just see someone in that sort of black and white way. Our goal is to open it up and see someone as the mother, as the educator, as the hobbyist, whoever the person is. We want to understand who they are and what's important to them, because that really helps us take better care of somebody moving forward when we're thinking about treatments. The other thing we're trying to do, which the other DBS team members are also trying to do, is understand what they're hoping for from the DBS treatment, and make sure that the hopes make sense. Sometimes people say, I'm hoping to stop the progression of my Parkinson's. Well, we know that unfortunately these therapies aren't proven to do that. So we have to make sure we reconcile what's actually possible with what they're hoping for. And so when we think about the medical options for people, when we're talking about goals of care, we talk about different procedures, whether it's deep brain stimulation surgery, whether it's duopa, the carbidopa, levodopa, intestinal gel, which Dr. Kern will talk more about. We talk about focused ultrasound procedures and so on. We talk about what's possible and what matches best with what they're hoping for. We think about the risks, benefits, and burdens of these treatments. The burden piece is something we talk about in our meetings too, because it's easy to look at risks and benefits and talk about those things, or relatively easy. But burdens is another thing. Perhaps you have to come back frequently to the clinic to get the DBS adjusted. Is that acceptable to you? For example. So this is another thing we talk about when we're trying to take hopes and goals and link that to the medical side. And then we also talk, as I said, about where people want to live and how we can best support them in that. So that's really the goals of care conversation, negotiating hopes and values with the medical treatments that are possible and realistic. And so that's one of the many places where we fit in discussions around advanced treatments in Parkinson's.
That's very empowering. It's informed and participatory medical care. It's very helpful. So Dr. Kern, could you touch on a little bit more about the other advanced treatment options?
Yeah, so if you, I guess, I think it's one of those slides kind of shows what we've done, yeah. So I'll just point this out here. If we go back to the previous slide. since I think the one where we have the Parkinson's Foundation here.
Oh, okay. Sorry.
Thanks. So I'll just point out that, we're the only center in the region that is a Parkinson's Foundation Center of Excellence, and we're very proud of that. And that is reflective about the multidisciplinary approach that we have at the university in the treatment of Parkinson's. And I think you're getting a flavor for that with just palliative care piece. And I think you've had a flavor with that with the DBS and the team approach that we have with how many individuals are involved in evaluating patients for DBS. With that in mind, if we go back to the core grant, the previous slide, thank you so much. Yep. It's not just DBS anymore. There is a number of advanced treatments, using that term still, for Parkinson's disease. And with that in mind, we've developed the University of Colorado Advanced Treatments and Movement Disorders program, where DBS falls under that portion of the program. And you can see here the overall goals of this program. So identifying barriers, for example, to patients, and what are those barriers for patients actually being referred to us from primary care providers, providing patient education. We're doing that even right now as we're talking. Improving access for us, so improving our referral process. So sometimes it might take months for a patient to get in to see us, but does it have to be months? Can we get them in sooner? Can we streamline the process a little bit better so that they're able to get to see the patients, the providers who they need to see? We ensure, of course, their diagnosis is correct. You've heard examples of that. And we also look at medications. So I've had referrals for patients for DBS who were converted from, example, carbidopa, levodopa, Sinemet, IR, immediate release, and they were converted to Ritari, which is an extended release formulation of carbidopa, levodopa, and they weren't responding. Well, if you actually looked at the conversion of this one patient, for example, the medication was cut in half because the conversion wasn't done right. So in actuality, as much as I love DBS, basically adjusted the patient's medication. He did great and didn't need DBS. So we optimize all medications. We also look at this not just in the motor perspective, but also a non-motor perspective. So if the individual has hallucinations, we'll treat that. If the patient has cognitive impairment, we address that. We always discuss, for example, constipation, address that. Palliative care is obviously very much involved in this because they address a lot of the other non-motor and the other care provider needs. You see the referrals that we will be placing as well. Then we talk about clinical trials, which cover in just a sec here, and then also surgical treatment options. And this is dependent upon what are really the goals of the care for the patient. And typically, during this, we might talk with our palliative care colleagues, Dr. Vaughan, about what did they find out during their appointment meeting and discussion with caregivers. And so the treatment options, in no particular order, really include adjustment of medications is probably the first thing to do. So if you've got really bad dyskinesias, you need to adjust your current medication regimen, lengthen the time period, reduce the dose, add adjunct medications, take away some medications, and be able to obtain benefit. That's just one example. Other examples are what we have are involved in clinical trials, are pharmaceutical clinical trials. So just as an example, we do have the impact study. Impact study, you can think of that as like Ritari 2.0. So that really is a 3-time-a-day dose of carbidopa, levodopa that's even slower dissolving over a period of time in the gut. So maybe that would be an option for a patient to want to pursue and enroll into a therapeutic, pharmaceutical, medication-wise clinical trial. We do have duopa or duodopa, also known as carbidopa, levodopa enteral suspension. This is a gel form of carbidopa, levodopa that's delivered through an AbbVie tube. That's basically a GJ tube. So it's a small tube in the stomach that goes out of the body, and then there's a small tube that's fed through that into the small intestine that then connects to an external pump that's connected to a gel. And you wear that, basically that pump in a fanny pack, or they have a sling that you could wear it on as well. We have both of the clinical trials that are subcutaneous, continuous infusion carbidopa, levodopa, including the one by AbbVie. So AbbVie, the same maker of duopa, duodopa, it also has a clinical trial improving upon their already developed regimen of a subcutaneous infusion. You can think of this kind of like a diabetic who's on an insulin pump. So the pump is about the size of a pager that you basically wear on your belt buckle, a small clip, or you can wear around your neck even, that has a small syringe that comes to a very small tube that then goes to a tiny, like 1 millimeter or so needle that just goes right under the skin. You wear that for 2-3 days, then you take it off. Literally, it looks like a sticker with a tiny, tiny needle, and you put it on somewhere else. And you hit play, and you continuously infuse that throughout the 24-hour time period. And that's a treatment option. We also have a gene therapy trial. So it's a surgical gene therapy called alpha-aromatic decarboxylase, or AADC. So it prevents the breakdown of levodopa dopamine further in the brain, improves on time. So patients who have really excellent response to carbidopa, levodopa, and maybe are not necessarily interested in having DBS, but are interested in dramatically improving their on time, likely will have to reduce medication with this sort of trial, can be considered to be enrolled in this gene surgical trial. And we also have DBS available as well, which I think most of your audience probably is at least somewhat familiar with. We were in the process of also purchasing a MRI-guided focused ultrasound machine. I know that's gained a lot of attention. That's a good treatment option and approved for tremor, unilateral tremor. It's not approved for any of the other symptoms of Parkinson's disease. So it's not approved for the treatment of rigidity, slowness of movements, freezing of gait, really only tremor, and only on one side of the body. And unfortunately, COVID hit us, and that really hurt the hospital's bottom dollar. So all large purchases were put on hold. We're having ongoing discussion to hopefully purchase that machine again in the near month or so. We've recruited a neurosurgeon who's starting up with us, who's from Stanford in the next month, and he's got expertise and experience on focused ultrasound. So hence we were really planning on having this technology available at our center much sooner prior to him coming, but it looks like hopefully maybe in a month or so, we'll have those talks up and going again, assuming that COVID numbers stay in our state relatively low. It's kind of an overview, and then of course we're looking at any new treatment options that come available for our patients, and those are always going to be evolved in clinical trials.
So speaking of clinical trials, I don't think the majority of us really think of that as a treatment option, especially maybe even later. So could you talk about the advantages of entering a clinical trial? Quick.
Pretty much any patient that comes to the university, you know, one of the biggest advantages of going to an academic institution is the access to clinical trials. There's a couple private community, neurologists, movement disorder neurologists who also are actively involved in clinical trials. But it's really helpful at an academic institution. You're pretty much guaranteed that they've got a number of clinical trials ongoing. And I look at this as really just another form of ammunition against this disease that I have available that other centers, other institutions, or other physicians just might not have. And so a number of patients might even look up clinicaltrials.gov as an example and find out that we're participating in a clinical trial and say, look, I'm really interested in this clinical trial that you're doing. I'm here to talk to you about that and see if I'm a candidate. So we've had some referrals for that as an example. The benefits of going into a clinical trial. Well, one, you're predominantly always seen by a movement disorder neurologist, so you get that expert care. Two, you have a number of appointments, a large number of appointments. So imagine seeing your movement disorder neurologist every couple of weeks, at least in the beginning. I mean, that's a lot of care that you're having ongoing. Three, there's a lot of scales that are also involved that can identify issues early on. For example, let's say an individual has impulse control disorders, but they're really mild and they never brought them up before. Well, on a number of these things, we do equip RS, which is a scale looking at and asking these type of questions. We might identify that, you actually do have a little bit of these symptoms and we need to pay attention to these issues. So you can identify this sooner. And then three, obviously you get the treatment option. a number of individuals I know might be concerned about participating in placebo trials. I would only add that with Parkinson's disease, there's a 30% response to placebo. So if I was to tell you, I've got this drug, it can provide you with a 30% improvement of your symptoms, and it has 0 adverse effects, I think everyone would say, sign me up. That sounds like the drug that I want to take. And that's how I think we have to think about placebo treatments as an option for our patients. So those are, and we know that the care that you get in participating in a clinical trial can be quite excellent and is excellent. And then after a patient exits those clinical trials, a lot of patients end up saying, can I keep you as my physician, as an example, since there's so much time that is spent with a physician who's involved in that clinical trial.
I'm sure you develop a great relationship.
It's worth mentioning too that a lot of patients feel really empowered by participating in trials, you know, contributing to the field, making a difference, staying sort of on the cutting edge of what's new in Parkinson's, and that can be really gratifying.
So I did have a couple questions in follow-up to what you were just saying, Dr. Kern. In the gene therapy, that's clinical trial, correct? That's not something that is FDA approved. That's their question.
Not FDA approved. It's clinical trial. It's called the Restore PD trial, if you wanted to look it up. RESTORE-PD.
And then also, are you doing the majority of your clinical trial visits via Zoom, or are you seeing them in clinic?
And that depends upon the trial and the sponsor. The vast majority of them are being done by Zoom. Some of the, if we have to administer drug or actually physically examine the patient, we are doing that now at the CTRC, which is at Anschutz, which is where we do all of our research. There are guidelines, i.e. number of patients that we've seen within CTRC, so you got certain windows, block times, etc. But a lot of sponsors have opened up to saying, hey, you can do Zoom for these type of appointments, which I've done for a number of our patients, but there are some appointments that still have to be done in person.
Awesome. So we talked about advanced therapies. Did you want to touch on advanced care planning?
How about
Sure.
Dr. Vaughan, you take that.
Sure, I'm happy to. Just briefly, this term advanced care planning is sometimes thrown around in the context of advanced therapies, but in reality, like everything else I've talked about, it should be something discussed as soon as, it's never too soon to discuss it. So just briefly, advanced care planning is planning in advance for what somebody would or wouldn't want in terms of medical treatment if they got really sick. And first and foremost, it's really two main parts. The first part is the medical durable power of attorney, naming someone to be your voice if you can't speak for yourself and documenting it. In the state of Colorado, that's particularly important because if it's not documented, there's no default. It doesn't go to the next of kin or the spouse. It needs to be documented. That's differing state by state, but that's how it is in our state. So just documenting that doesn't require an attorney or fees or anything at all. You just write it down on one of these forms that you can find online. And the second part of advanced care planning is either a living will, or as I mentioned earlier, a MOST form, a medical orders for scope of treatment, where you indicate, you know, if something catastrophic happened, my heart or lungs stopped, what would I want or what would I not want? In other words, attempts at resuscitation, yes or no. So there's a variety of forms, some short, some long. Again, it doesn't necessarily require an attorney or any sort of professional. It really just requires a conversation with your medical team, your neurology team, to get these things documented and in order. And it brings about a lot of relief for people to know that this is all documented, taken care of. We don't have to belabor the point, it's done. So that's what advanced care planning or advanced directives are. And I think they're always important. Certainly before someone goes into a surgery or a procedure of any kind, we want to make sure those are clarified.
Awesome. So I have a few questions from our audience. One person said, I was in denial the first few years. Now I wish I could go back in time. I think, you know, once we realized that we could have had a say a little more into what quality of life was for us and what our goals are would be helpful. And then a couple of questions about how to get involved in palliative care, like how to have that conversation with your doctor, how to, in some places don't necessarily have a program like yours. So how can they get that same type of care?
These are great points. So to the patient or to the person that wrote about wishing they could go back in time, you know, I hear you. I would also say that there are always things we can do to help quality of life as a team. So it's not too late to work on sources of joy, ways to get meaning out of a day. And it may sound easier said than done, but it's doable. So the trick is to work with someone that's committed to helping you live your best life at whatever stage you're at, you know, because things are better now potentially than they might be years from now. So we got to seize the day now. So that's what I would say to that first person. And then when it comes to palliative care, just by hearing this conversation and learning or reviewing what palliative care is, can prompt you to trigger these kinds of conversations with your doctors or your medical team, whether or not there's a palliative team or not. So first would be talking about advanced care planning and making sure any questions you have about that are clarified, and then documenting it, and talking about what your goals are, what you're hoping for, and sharing that with your team, and then being your own advocate and asking for more support or asking for caregiver support, because the caregiver, the spouse, whoever's close to you, close to the person with Parkinson's, is part of it. We all know that Parkinson's doesn't just affect the person with the diagnosis, right? So making sure that everyone's advocating for as much support and help as possible, because as somebody said earlier, I think Anissa, we don't know what we don't know. So having as much conversation with your medical team, whether or not it's a palliative team, as possible, really helps get more support.
One person said, I never had such a conversation with my doctor, but after hearing something like this helps to open up that conversation with your doctor. Now, you just mentioned, you know, care partners and family members. So this person says, I'm unmarried and without children and have to act as my own care partner. What kind of things do you suggest, or how do you help those who are single and may have a very limited support system?
It's a great question. I'll chime in on this one. I think that tapping into the Parkinson's community at large can be helpful, because nobody really understands what you're going through unless they're in your shoes, and nobody's really in your shoes, even if they have the same diagnosis. But other people going through Parkinson's get it a lot more than the average person. And so I think tapping into other Parkinson's groups or people with Parkinson's in your area or even online can be helpful. And then tapping into any sort of community that you maybe were attached to in the past and reconnecting with them. It's so easy in Parkinson's to isolate, right? Especially during a pandemic, and become detached from old links that we had in the past, faith groups, social groups, whatever it is. And trying to reconnect with those groups isn't just good for your own support, but it's good for your brain. So reconnecting as much as possible with friends and family, and tapping into Parkinson's resources community within the Parkinson's world. I would suggest those in particular.
Awesome. So Dr. Kern, I'm going to go back. Somebody had asked a question and just need to clarify. Did you say Rytary 2.0 or was that Duopa 2.0? I know you mentioned the new pump that's in trial now. I think that's what you were referring to. I just want to clarify that.
Yeah, so the trial name is IMPAX, IMPAX, and it's the sponsor is the same sponsor who makes Rytary. Okay. And some people are giving the name, this is Rytary 2.0. So Rytary, as you all know, we were really hoping that would be truly a 3-time to 4-time a day drug. Unfortunately, that's just not what's really panned out. A lot of patients are taking it 5-6 times. It certainly does reduce dyskinesias and improves on time, but not to the degree that we had all hoped that it was really going to be a 3-time a day drug truly. And so the company has come forward and said, we're going to remake this and change it, the formula, to make it really a 3-time-a-day drug. And hence that's what people term it as Rotari 2.0, if that makes any sense. Duopa is not having a new pump, i.e. carbidopa, levodopa, and suspension. It's the same pump. But the other pump therapy I was mentioning was the subcutaneous, so just under the skin infusion, and that does have a very small pump that has a size of a pager. Now, if you're familiar with this, the same company has come out with a newer pump for the subcutaneous infusion as well, that is going to be used for now their randomized control trial of subcutaneous continuous infusion of carbidopa-levodopa.
All right, so we just have a couple more questions. I don't know if anyone has anything that they want to follow up with either Dr. Vaughan in terms of the palliative care or Dr. Kern in terms of the advanced therapies. Someone wanted to know how close this impacts to developing the 3 times a day.
Yeah, I can see some of these, so I can run through it very quickly. So that's in a randomized controlled trial, so hopefully it's going to be successful. So that's ongoing, be about another year, and then after about a year, then hopefully based upon the results, they take it to the FDA, hopefully for approval. It's not bad to be taking Rotari 5 times a day. A lot of my patients end up taking it 5 times a day. You take it based upon the adverse effects that you're having, i.e. the off time that you're having, and to mitigate any type of dyskinesias. Because they feel uncomfortable. No, it's fine to be taking it 5 times a day. I think that's what the one person is referring to. What I'm trying to find out is whether I have to. So the Rotari with the new capsule. So if you're on Rotari and you want to go be considered for the IMPACTS trial, they enroll you, they convert you basically to carbidopa-levodopa IR, and then you're either randomized to carbidopa-levodopa IR or to the IMPACTS drug. So you're go into either one of those arms. And I saw these other questions about idiopathic chorea. We do see chorea, and idiopathic chorea means idiopathic. The word simply means I don't know. So I don't know chorea, meaning you have chorea, but I don't know why you have it. There's an extensive workup that's done for evaluating chorea. Obviously, the most common cause is Huntington's disease, but I think that this individual already mentioned that it wasn't Huntington's. So there's a large workup that's done. We do have the Huntington's Disease Center of Excellence as well. Most of those patients are seen by Dr. Lauren Seeberger, Seeberger. There are a number of medications that can control dystonia. Toxin injection, botulinum toxin is something that we do quite a bit of, and that's done by Dr. Vaughan as well as by myself and a number of other providers.
Awesome. All right, we only have a couple more minutes left, and I want to thank Dr. Vaughan and Dr. Kern for joining us today, giving us your time during your lunch, and sharing your insights. It's exciting to hear all of the advanced treatment options that are available and the role that clinical trials play in helping us get there, plus giving us an opportunity to get involved in that care. And then knowing that there is a model of care that allows us to have more of a say and define what quality of life means for us with palliative and how they work together. So it's nice to be able to kind of put those two together. So thank you so much for your time today and for that information. I just want to point out a couple of things for our audience today in terms of upcoming events. So we do have an online interdisciplinary care and telehealth rehab coming up on the 31st. We also have our virtual happy hour on Friday, Shaken Not Stirred, if you want to join us for that. And I don't want you to forget that we're also in the midst of doing our Inspire Me raffle, which is our online raffle featuring artwork from people whose lives have been impacted by movement disorders. The tickets are $25 and the raffle's running through August 2nd. The proceeds are benefiting programs just like this one that you might find inspirational. So we invite you to go online to our website to learn more information. I want to thank everybody for joining us today. Again, thank you, Dr. Kern and Dr. Vaughan, for your time and joining us. And as we get ready to exit, if everybody would want to wave goodbye to our friends, we will see you next time. Thank you so much. Have a great afternoon.
Thank you. Take care.
Thank you.